All right, let's jump right in. Septic shock. It's one of the highest stakes situations you'll ever face in the ICU. Your patient's blood pressure's crashing, their organs are in danger, and every single second counts. What you need isn't a textbook, it's a playbook, and that's exactly what we're going to build right now. So get in a zone here. You're in the ICU, alarms are blaring, your patient with sepsis is now officially in septic shock. Their mean arterial pressure, their MAP, has dropped to 60. The clock is ticking. What is the very first drug you reach for? This isn't just an academic question, right? This is the reality. Okay, before we even touch a drug, we need a target, a North Star. And for us, that is a mean arterial pressure, a MAP, of at least 65. So why 65? Well, that's kind of the magic number we need to make sure enough blood and oxygen are actually getting to the vital organs, like the brain and the kidneys. Everything we do from this point on is about hitting and holding that number. So how do we get that MAP up to 65? Well, that brings us to our most important tool, our number one, our first-line agent. This is the one you've got to know inside and out. And here it is, norepinephrine. The Surviving Sepsis campaign says this is the first drug of choice, and for a really good reason. It's kind of the perfect combo. It's got the strong alpha-1 effect, which is what really squeezes the blood vessels to crank up that blood pressure. Then it has a little beta-1 kick to give the heart a gentle push. And maybe the best part, it does all of this with the lowest risk of causing dangerous heart rhythms compared to the other options. It's effective and it's relatively safe. Look, let's just boil it all down. If you walk away remembering only one single thing from this entire explainer, make it this. For septic shock, your first thought, your automatic reaction should be norepinephrine, period. But what happens when norepinephrine isn't quite enough? You know, sometimes you're cranking up the dose, but that MAP just refuses to climb past 65. That's our cue. We need to bring in some backup. We need more firepower. So this slide lays out our next two moves perfectly. Our second-line agent, the one we add next, is vasopressin. We bring it on board when norepinephrine alone just isn't cutting it. And what's cool is that it works on a totally different system, the V1 receptors, so it's like attacking the problem from a new angle. Now, if the patient is still hypotensive after both of those, then we consider our third line, epinephrine. It gives a massive alpha and beta boost, but you gotta be careful. Look at that warning. You have a much higher risk of arrhythmias, and it can spike lactate levels, which can really confuse the clinical picture. Now, here's a super important point about vasopressin. It's dosed differently. See, unlike other pressors that we're constantly turning up or down, vasopressin is usually run at a single fixed dose, 0.03 units per minute. You basically set it and forget it. And the reason for that is that patients in septic shock are often just plain deficient in their body's own vasopressin, so this dose is really just a replacement therapy. Okay, so far everything we've talked about is squeezing the pipes, vasoconstriction, to raise the pressure. But what if the problem isn't the pipes? What if the problem is the pump, the heart itself? This is where we pull a different kind of tool out of the box, an inotrope. If you've got signs that the heart muscle is weak, what we call myocardial dysfunction, then the drug to add is dobutamine. Its whole job is to help the heart squeeze harder and pump more effectively. But, and this is a huge, huge but, dobutamine can actually open up blood vessels a bit, which can make the low blood pressure even worse. This is so critical. You almost never ever give dobutamine by itself in septic shock. You add it on top of a pressor like norepinephrine, which is already squeezing the pipes and can counteract that dangerous side effect. All right, we've gone through all the individual players. Let's put them all together now into one simple, step-by-step game plan. This is your high-yield ICU playbook.
Here it is. It's this simple. Step 1, you always start with norepinephrine, aiming for that MAP of 65. Step 2, if that's not getting the job done, you add vasopressin at its fixed dose. Step 3, still in trouble? That's when you consider adding epinephrine. And remember, running in the background of all this is step 4. If you ever figure out the heart pump is weak, that's your trigger to add dobutamine to whatever else you're already doing.
Let's wrap this up with some rapid-fire gotta-know pearls. 1. Start these drugs early. Don't wait around. 2. It is absolutely okay to start them in a peripheral IV for a short time while you're getting essential line. 3, and this is the most important thing, pressors are just buying you time. You have to treat the infection with antibiotics and source control. And 4, always remember the goal, a MAP of at least 65. So you've used the playbook, the numbers on the monitor look better, the pressure stabilized. But that brings us to the final, most important question of all. With the blood pressure temporarily fixed, what is the single most important thing you need to do to actually change whether this patient lives or dies? And of course, the answer is to treat the infection. These drugs are just a bridge to get you there. They are not the destination.